Hey there! This video is going to provide a super quick overview of the most common inotropes and vasopressors you're likely to encounter during your PICU rotation. Let's get started. First, some terminology. Although they're often used somewhat indiscriminately, inotropes and vasopressors are not the same. Inotropes cause the heart to beat more forcefully, while vasopressors increase systemic vascular resistance. Both are used to increase blood pressure in patients in shock, with the ultimate goal of maintaining or improving end organ perfusion. To know which type of agent to start first, it helps to think about why the patient is hypotensive to begin with. In any context, pressure is flow times resistance. In terms of blood pressure, this means that systemic blood pressure is the product of cardiac output and systemic vascular resistance. Patients become hypotensive because of inadequate cardiac output and/or decreased SVR. In conditions such as hypovolemia, bradyarrhythmias, and cardiogenic shock, hypotension can be traced back to low cardiac output. The body compensates for low cardiac output by increasing SVR to try to maintain blood pressure. These patients look clamped down. They have poor peripheral perfusion and slow capillary refill. To actually treat the underlying issue, you want to improve cardiac output. Give fluid to increase preload, inotropes to help contractility, chronotropic agents for bradyarrhythmias, etc. You may also want to decrease your SVR by reducing afterload to reduce the amount of work the heart has to do. These patients are already vasoconstricted, so vasopressors are not the answer and could potentially make things worse. When SVR is low, on the other hand, the body compensates by increasing cardiac output. These patients are those that come in things like distributive shock or anaphylaxis. They're hyperdynamic with flash capillary refill and bounding pulses, the stereotypic warm shock picture. The actual solution here is to increase your SVR. Agents that will do so, like norepinephrine, are the most helpful. Inotropic agents are less useful because the patient is already hyperdynamic, and making the heart beat more forcefully does not fix the problem. Once you've decided what underlying issue to address first, you can choose an appropriate agent with which to do it. This table provides starting doses and titrations for some of the most common vasoactive agents we use in the PICU. Some agents are primarily inotropic, such as epinephrine and dopamine, whereas others have primarily vasopressor effects, like norepinephrine, phenylephrine, and vasopressin. One additional agent you are likely to encounter is milrinone. It's an inotrope, but unlike the others on this list, it's not used to augment blood pressure, as it will actually tend to lower pressure. It's used specifically in patients with impaired cardiac function. As you might expect, classifying these agents as simply inotropes and vasopressors and leaving out any discussion about their receptors or mechanism of action is a gross oversimplification, and it's kind of killing me not to get to tell you more. But the point of these videos is to help you become familiar with some of the things you're likely to see in the PICU, so I'm going to have to stop at this for now. Hopefully you'll get to talk more about the details of how these agents work and how to use them to help your patients during your rotation. So, to summarize, here are a few big ideas to take away from this video. First, the vasoactive agents we have discussed are used to augment cardiac output or SVR, thereby increasing blood pressure. In most cases, you should not rely solely on these agents, but should also give fluids, which will increase preload and optimize the Frank-Starling relationship. In almost every situation, you should actually start with the fluids before you move on to the vasoactive agents. Keep in mind that no matter how many vasoactive infusions you start, identifying and addressing the underlying cause of the hypotension is ultimately the most important aspect of successful treatment. That's all I have for now. Thanks for listening.